Hey everybody, welcome back to Spot Check here. We're going to go over a high yield lecture series continuing down the genoderm pathway here. We're going to talk about Epidermolysis Bullosa and the various subtypes, genetic subtypes thereof. Hey, let's give a big thanks to Max here, OMS, that is working on, or at least created this PowerPoint for us. Give him a big thank you in the comments down below. So ultimately, in a very, very broad sense, epidermolysis bullosa has mutations within genes that encode structural proteins in the skin. And these proteins, based on where the mutation is and where the protein location is, that determines where the blister forms, typically. And that can give you some clues, especially with some of the features that it presents with. Ultimately, you got to know the genetic transmission, the type of skin manifestations that show, and where the blister forms. There are a couple different diagnostic criteria, but we are moving away from the clinical phenotype and kind of guessing based on presentation to pure molecular analysis of the defect. So EB, just in the general sense, the prevalence here, 11.1 per 1 million live births, incidence 19.6 per 1 million live births. Carrier frequencies and prevalence and indices are all kind of mixed up here based on the subtype. So EB 6.0 to 7.9, and they're just kind of listed out here. EB simplex being the most common. And to break down these larger subgroups and kind of give a understanding what's going on at EB simplex, just to give you an idea where the blister forms, EB simplex forms in the intraepidermal space, while junctional EB forms at the ultrastructural site like the intralamina lucida. Dystrophic EB is sublamina densa, and Kindler syndrome is mixed. So just kind of, in case you have an understanding of this, or if the question format helps you a little bit with trying to understand or ascertain where these types are, and we talked a little bit in the past, in the last slide, about where these splits are. This can give you an idea of what diseases are blocked out here on the right. So the upper disease here, we see that in EB simplex, okay? And that's why we have splitting in the upper level layer of this lamina densa structure. You go above that. Here, junctional EB happens at the lamina lucida here, located there, pointed by the arrow. And at sublamina, we have dystrophic EB. So starting out, we have EB simplex here. Most of the time, the transmission here is autosomal dominant. There are two major subgroups of EBS. They're suprabasilar, and these genes mutated are usually like TTG5 and acropeeling skin syndrome, or plakophilin-1, plakoglobin, desmoplakin. The basal subset split usually, and these are the more common ones, keratin 5, keratin 14 gene. And you saw that on the last slide here. I'll point it out here again. There's keratin 5, keratin 14 just below the EB simplex arrow. Now, when you have blistering that occurs on the palms and soles and worsened by warm weather, you want to think of more localized disease because it's only on the palms and soles. There are two names now. There was a eponym name. So I'm going to say both, but the world is kind of moving from the eponyms and now going to the more better, more descriptive names. So in this case, EBS localized is going to be blistering in palms, soles affected by weather. It was previously called Weber-Cockayne. Now, if you have more significant mutations with keratin 5, keratin 14, you could have generalized severe, and that's going to be previously called Dowling-Meara type. There's also autosomal recessive EBS, and these are mutations in plectin, and that one's associated particularly with muscular dystrophy, or mutation in alpha-6 beta-4 integrin, which is associated with pyloric atresia. So these recessive subtypes usually have some sort of other manifestation associated with them. They keep going down that. So we talked about Dowling-Meara, also generalized severe. We talked about EBS simplex, Weber-Cockayne. There's also a generalized intermediate, or Kebner. So that's kind of how it breaks down. Is it generalized intermediate, generalized severe, or is it simple? And here on the right, we have a couple just pictures to help demonstrate what the intermediate EBS looks like in the, or I'm sorry, what the intermediate EB looks like and what the generalized EB looks like in terms of EB simplex. Localized is not pictured on the right here. And keratin filaments, you'll notice there are large electron-dense clumps based on what type of microscopy you're using in the severe subtype, also known as Dallimera. This is typically absent or reduced in autosomal recessive EBS. Suprabasilar forms of EBS usually have an acantholytic component to them. You might see keratin filament perinuclear retraction or small suprabasilar desmosomes. Now, going specifically in the localized subtype, this is the mildest form, often the most common. And then you want to know where is the split, what's the defect. So one way you can remember this is you have 5 fingers, 5 toes per hand and foot. So if you have 5 fingers, 1, 2, 3, 4, 5, you can think of keratin 5 and keratin 14, which 1 and 4 adds up to 5. So yes, keratin 5, keratin 14. And now remember, this is an intraepidermal split here with EB simplex. The generalized intermediate form, you can have tense bullae at any site of friction, sometimes occasionally more mild but oral mucosal erosions, usually worse during normal or warm temperatures. Normal lifespan is expected. And now with severe, the Dowling, or previously called Dallimera component, you usually see this at birth, generalized blisters after a few months, and then they actually look herpetiform in nature. The blistering erosions can progress to the oral cavity and esophagus. You have a confluent PPK, so the pulmonary and acral aspects are often significantly involved. Nail dystrophy is prominent in this one in terms of the EBSs. This is the most severe form of EBS, and do note that this box here is supposed to show that there's clumped tonofilaments on electron microscopy. Another more rare EBS subtype is the mottled mottled pigmentation subtype. You'll have mottled hyperpigmentation on the trunks and limbs, non-scarring, blistering, and reticulated hyperpigmentation. Now here, if you want to know the mutation, it is the rare heterozygous point mutation at P25L, and that is a non-helical V1 domain of keratin 5. Keratin 5, it fits, right? We know that EBSs are exposing or at least showing some sort of mutation in keratin 5 or keratin 14, so it makes sense that the mutation here is keratin 5. EBS muscular dystrophy, now remember, this inheritance pattern, autosomal recessive. You're going to get the muscular dystrophy component and you're going to get an EB simplex. So you're going to notice bullae at birth, mild, muscle weakness, usually delayed, and the gene affected here is plectin. The pyloric atresia subset of EBS, some call it Carmi syndrome, usually have the bullae at birth, and you even are sometimes born with the pyloric atresia. Complications beyond this include some fusion of the skin of the fingers and toes, some nail abnormalities, joint contractures, alopecia, malformations of the urinary tract. That's pretty important, malformations of the urinary tract as well. High mortality is associated with this, and there are some major surgical challenges. Now, the mutation here is plectin, but also alpha 6 beta 4. Now, how do we remember that? If you look at beta, it actually looks as if the stomach would have a kink in it. So think of that, or think of that as like the invagination of the beta from the loops as a kinked, either esophagus or urinary tract. And that could be a good way of helping you at least somewhat remember that mutation in that specific subtype. Here are some other clinical images here. Do note severe nail dystrophy shown here on the bottom left. That's usually with generalized severe. Generalized severe can also have a diffuse palmar keratoderma in adulthood, noticed in the bottom middle. Right side is the intermediate form where you have extensive blistering because it can happen everywhere, but it can also significantly involve the feet. And then another type of EB simplex severe in the middle upper. We're showing clustered vesicles, those herpetiform-like lesions in an arcuate array. A little bit of a recap. Where is the split? The split is intraepidermal. What's the most common form? EBS. We're going to go over the other ones here soon. What's the most severe type of EBS? Dallimera. What's the inheritance? Typically autosomal dominant, unless you have some unique associations with other systemic organs, then you're going to more likely look at autosomal recessive. Now, these bullae generally heal without scarring, and that's going to be important. It will help you kind of attempt to differentiate clinical exams with the other EBSs. Ultimately, prognosis pretty good. It can be debilitating, especially with the severe variant. There is a mortality associated with it early on. Is the component for NICU admission based on the Ebola burden, and also if there's other organs affected as well. And here is a good differential to make you think, beyond just the genetic conditions as well. Now we're going to go into junctional EB. Junctional EB, remember, junctional EB is a mode of transmission is predominantly autosomal recessive, and there are some major subtypes we're going to go through here. Predominant JEB or junctional EB. There is the severe subtype, previously known as the Hurlitz, and then intermediate subtype known as the non-Hurlitz. Now, we're going more towards severe, going more towards intermediate, and not using the eponyms, but I want to give you both. Of note, this is huge, high yield, and I don't say that too often, high yield, okay? JEB, all forms will have some sort of enamel hypoplasia and pitting. So if you have teeth involved, strongly consider JEB to some degree if you're considering a EB. Other disorders, pyloric atresia. Remember, beta 4. Remember the invagination. Remember the stomach kinking. Beta 4 can be associated with pyloric atresia. Also remember, respiratory and renal involvement can be associated with JEB, and that's more of an integrin alpha 3 chain mutation dysfunction. Junctional EB here. So typically the blister happens here at the dermal epidermal junction, right there. Okay. What you might notice in the intermediate form of JEB, there is a small hemidesmosome that is retained, but ultimately the split is at the dermal epidermal junction. Subbasilar dense plates in anchoring filaments can be noted. That's what this is trying to demarcate here on the right. And also, these are absent in the severe form. Hemidesmosomes can be absent or sparse in the severe form, normal or reduced in the intermediate form, if you're asked about electron microscopy in some way. Now, going into the severe subtype, genetic dysfunction here, the genes that are often involved include LAMA3, LAM3, LAMC3, or LAMC2 gene mutations, and these encode for polypeptide chains within laminin 5. What you're going to see here is the onset's pretty rapidly at birth. The skin, you're going to have generalized bullae without scarring, but there is going to be a significant amount of granulation tissue, and that can help clue you in to JEB specifically. Nail shedding is more prominent in this disorder as compared to the previous, so look out for that. A hoarse cry. These patients will have a hoarse cry or an abnormal cry due to laryngeal involvement. Musculoskeletal growth will be retarded in some way, and there's a 90% mortality early on. Laminin 332 is another name for laminin 5. Also, mutations can happen in collagen 17, which would be BPAG2, or BPAG2, another name. Also BP180, all things that describe collagen 17. Your characteristics here for non-Hurlitz JEB, or the intermediate JEB, junctional EB, is generalized blisters and oral involvement that improves with age, nail dystrophy, scarring, alopecia. The child will typically heal, with some atrophic scars over time. And the prognosis here, usually there is a survival to adulthood. Pyloric atresia, junctional EB. Remember, alpha 6, beta 4. Picture that beta. Hope that's a good handhold for you. So you're going to get pyloric atresia involvement, and you're going to have urinary tract involvement. Remember, the beta is to signify any sphincter squeezing. So that also includes the urinary tract. This has a high mortality in infants. There are also JEB with respiratory and renal involvement, or JEB-RR. This is an integrin alpha 3 mutation, or ITGA3 gene. You'll have a congenital nephrotic syndrome, interstitial lung disease, and this has an early death. This is a pretty rare disorder, so only 8 cases reported as of 2022, but good to know these things. It's important to know these things. Some clinical images here. What I want to point to you as if someone was to force you to try and attempt to make a diagnosis based on just the picture. First off, they're incredibly mean, and second off, You'll note here you're going to have an exuberant amount of granulation tissue, and that's kind of a helpful thing. Differential diagnosis is here. The prognoses also are listed here. Hurlitz, which is your severe type, usually fatal within the first year. Non-Hurlitz, your intermediate type, does improve with age, but can be a challenge. Not necessarily limiting you in your livelihood, but it can be challenging. And then pyloric atresia subtype is usually fatal. So what's the summary here? Where does the blister split happen? Lamina lucidum at the basement membrane zone between the epidermal dermal junction, okay? This is your rarest form of EB. This is often an autosomal recessive disorder. It occurs in all forms of JEB. What is that? Enamel hypoplasia and pitting. I know I don't have any teeth pictures in here, but like seriously, if you see teeth involved and it looks like an EB, and they're going to make you diagnose it without any genes or without any mutations or granulation tissue, etc., go JEB for the most part. Now we're moving on to dystrophic EB. Dystrophic EB, lots to break down here, but typically the mutation is in some sort of collagen 7 mutation, collagen 7A1. And that's going to be important later on because I'm going to briefly talk about this incredibly new advancement in technology that we have. Now, gene dysfunctions, you have dominant DEB, dominant dystrophic EB, recessive dystrophic EB. You have recessive dystrophic EB severe, recessive dystrophic EB intermediate, and dominant dystrophic EB. So it gets a little confusing here. Basically, let's look at the two main subtypes. Dominant DEB. This is typically a dominant negative missense mutation causing protein structural abnormalities. Your staining of the DEJ will be indistinguishable from normal skin, at least your IHC staining. Recessive DEB is a compound heterozygous mutation within the type 7 collagen gene. If type 7 collagen's NC1 domain is retained, there's an increased risk of squamous cell carcinoma. Now looking at the subtype specifically, the haloposemins are also known as recessive dystrophic EB severe, has premature stop codons, usually causing truncated protein. So that's a little more severe, right? You have proteins that are just like chopped off and completely non-functional. Recessive dystrophic EB intermediate, also non-haloposemins, usually more biallelic mutations, less severe in the type 7 collagen gene, creating defective anchoring fibrils. Dominant DEB is a missense mutation of collagen 7A1 that is typically seen in the Caucasian terrain type or the Pacini type. So moving on to, here's just these blown up a little bit. If you want to pause it and look at it a little bit, your eyes might be not what they used to be. You can pause them, look a little bit forward, look a little bit ahead. But we're going to talk about this, okay? Like we talked about the three major types. Here is a graphic depicting the split and kind of some things that you might notice of the ultrasexual sites as they split and what might help clue you into certain disease states. So the blister formation site for sublamina densa cleavage of all types, you're going to have a blister roof with intact epidermis, attached basement membrane with a lamina densa. Notice, that's depicted here. So the blister cavity shows that the lamina densa is fixated to the overlying basal cell. Okay? Now in DDEB, you're going to have your anchoring fibrils are going to be normal in size and structure, just reduced in number. And sometimes they will even be retained to the blister roof, and that's where they are right there, okay? In recessive dystrophic EB, you might either have no anchoring fibrils, or some just sparingly. And that correlates with disease severity. Going over the severe type of RDEB, that is collagen 7, that's an autosomal recessive inheritance. This one, some key things I wanted to put in your head, so that you can help differentiate this from others if you see these severe variants. Mitten deformity or pseudosyndactyly is prominent, okay? Notice that here on the hands. Limb and digit contractures, also noticed here on the right side. You can have renal failure, you can have aggressive squames. You can heal with atrophic scarring and milia, and you can have generalized mucocutaneous blisters. Now, there's a high mortality risk with the SCC burden. Intermediate subtype, very similar. You're going to survive to adulthood, though. You're not going to have as much of a SCC dysfunction or SEC predominance, you know, and you're following you. And this is going to ultimately improve over time. Dominant dystrophic EB, it's a genetic defect, obviously, in collagen 7A1, as is the others, but this one's an autosomal dominant type mutation. Nail dystrophy, oral blisters are noted, and this begins at birth and improves over time. The Cockayne terrain type usually has generalized blisters over the extensor joints, and this has atrophic scarring amelia. So the Passini type, generalized blisters over the extensor joints as well. Okay, now the unique variant of this and what is tested is that there are some spontaneous white papules on the trunk without the preceding blister that's noted. So you have spontaneous albopapular papules on the trunk without preceding blisters. Okay. And on the right here, you're going to notice you're going to see your scarring. It's obviously pretty evident on the hands here on B. You're going to note even a little bit of nail loss as well. I mean, they're almost gone. Not even a little bit. All the nails are gone except for his thumbs. And then here, you're going to have a discrete area where you see some crusting, but you also notice some fine milia. And this will likely scar to a degree. So there's also bullous dermolysis of the newborn, which is a rare form of DDEB, and it's a dominant inheritance, but usually you only have this transiently for the first 2 years of life. Do note in DDEB there's a normal lifespan, debilitating blisters. It improves over time. And then RDEB, being that there's an intermediate mild subtype and there's a severe subtype that obviously helps you clue in what your morbidity is going to look like. Severe subtype, you're going to be more at risk for infections, anemia, malnutrition, and the high mortality from a squamous cell carcinoma. Now, Kindler syndrome here is an autosomal recessive dysfunction, inheritance of a gene dysfunction called the FERMT1 gene, which encodes Kindlin1. And note here that there's some other characteristics that are more unique to this syndrome. The other name for it is hereditary acrokeratotic poikiloderma, which will help clue you into these other characteristics. So, photosensitivity, progressive poikiloderma, cutaneous atrophy, mucosal inflammation, trauma-induced blisters, and an acral blister distribution typically. The atrophy, acral blister distribution, and the photosensitivity are all the clues to give you Kindler syndrome. Because, right, if you think about it, nothing else really causes a photosensitivity. Acral blisters can be found in some of the other ones mildly, you know, depending on which EB you're looking at. But usually you don't see the acral blisters and atrophy paired together, and then the photosensitivity is another good giveaway. You're going to notice here is you're going to have increased skin fragility that decreases with age. You're going to have increased risk of sunburn, but improves with age as well. You're going to have a reticulated hyperpigmentation and telangiectasias, and that usually happens in the sun-exposed areas as well. Poikiloderma, webbing of the digits can happen. Poor dentition or erosive gingivitis. Increased risk of squamous cell, maybe secondary to that photosensitivity component as well. Your skin biopsy might show epidermal atrophy, vacuolization of the basal cell layer, variable epidermal melanin contents, dermal melanophages, capillary dilatation, and the electron microscopy might show duplication of lamina densa as well. Immunostaining for anti-Kindlin1 antibodies will show a significant reduction in that. Keep in mind other poikilodermic syndromes like Rothman-Thompson, as well as your other forms of EB as well. Here are some clinical photos here. I mean, these guys look like they're burnt to a crisp, right? Erythema and atrophy noted, especially on B, especially on the side of A here. And then also you're going to notice some wrinkling because of some atrophy, and there's some mild fusion of these toes as well. Here are some unique subtypes. This is kind of a good way to help, you know, distinguish some cutaneous findings. If you're super stuck, we can go through them briefly. Palms and soles only, EBS, EB simplex localized. Axilla and groin, there is sometimes inversa subtypes of both dystrophic and junctional EB. Herpetiform blisters, do note that is EBS generalized severe. Reticulated hyperpigmentation, EBS with mottled pigment. Excessive or exuberant granulation tissue, periorificial, axilla, neck, upper back. Remember, and I hammered this, junctional epidermolysis bullosa, typically the severe variant. If you have a confluent, like completely encompassing the palmar plantar aspects of your feet, that is EBS severe. And occasionally there are prurigo-like nodules as well. So you can have prurigo-like nodules coalescing into linear plaques on the shins, and that is a dominant dystrophic EB pruriginosa. Now the treatments here. Treatments are tough. EB is one of the toughest things to treat. And there's really not a great... Nothing fixes it right now. I mean, just to be kind of quite frank with you, there is something on the horizon which is starting to help, and I'm curious to see how this will go in the future. Of course, this being an orphan disease to a degree, it's going to take some time before we build up enough cases to see the response with this, but I don't want to spoil it. We'll show you here at the end. Anyhow, treatments aimed at managing the symptoms which patients experience. You're going to need to see specialists based on what's being involved in terms of, is it dentistry, is it GI, is it renal, uro, onc, giving squamous cell burden and other cancer burdens, ocular occasionally, cardiac occasionally. So notice here, wide potential complications listed below. Often some of these we talked about, some of them beyond the discussion here. Key things you can do in terms of counseling: you can have them avoid mechanical trauma, any mechanical friction, especially in the more severe subtypes of recessive dystrophic, dominant dystrophic, junctional. Any mechanical trauma can form new blisters. Infections, these patients will be really at risk for infection because their skin barrier compromises pretty easily. And for wound care, the general rule is just making sure that you're avoiding non-adhesive or avoiding adhesive dressings completely so you don't form new blisters. There are several dressing types listed here: silicone, low tack, non-adherent lipocolloid dressings, hydrogel, foam, absorptive, silver-containing, antimicrobial dressings. All can be super helpful. They are not adhesive. They're not going to form new blisters. They'll help prevent some lateral mechanical friction. Now, if you have patients with EB, or if you see one, these are good websites to help clue the patients in, or at least the patient families in, have them understand what's going on and get a better understanding of the disease. So let's kind of go over some things here just to hammer home some key points here. The EB here that has a dominant negative mutation of keratin 5 or 14, blistering mainly on the palms and soles of the hands. What's the answer? Think about it. All right. It's EBS localized. Okay, the other name being Weber-Cockayne. Now, if we have EB that's characterized by atrophy, acral blisters, and photosensitivity. Remember that photosensitivity is your key here for Kindler syndrome. The subtype of dystrophic EB that is characterized by a lack of anchoring fibrils. So remember back to that photo I showed you where there was some anchoring fibrils, there was completely retained anchoring fibrils, and there was no anchoring fibrils. Which one would that be? You're right, recessive dystrophic EB. All right, let's match these up. So where is the split for EB simplex? Think about it. Dystrophic EB? Okay. Kindler syndrome? Yeah. Junctional EB? All right, we got it all. Ready? See if you're right. Yeah. Good job. EB simplex here, intraepidermal. Junctional EB, intralamina lucida. Dystrophic EB, sublamina densa. And Kindler syndrome, mixed. All right, Kindler syndrome. What is the characteristic electron microscopy finding? Clumped tonofilaments, rudimentary hemidesmosomes, absent anchoring fibrils, duplication of lamina densa. And bonus points if you tell me what the wrong answers are actually correlated with. Good job, good job. You knew that A was associated with epidermolysis bullosa simplex dowling marrow, which is the severe variant. You knew that rudimentary hemidesmosomes are noticed in generalized severe junctional EB. You knew that recessive dystrophic EB has absent anchoring fibrils, specifically the severe variant. And you also knew that duplication of lamina densa is the electron microscopy giveaway for Kindler syndrome. Good job. More matching, okay? Put these subtypes of EB with their type of mutation or their finding. So, clumped tonofilaments, where are we going to see that at? Okay. Missense mutation in type 4 or type 7 collagen causing an altered structure. Yeah. How about a premature stop codon for type 7 collagen with absent anchoring fibrils? How about a premature stop codon in the pathway encoding laminin 332, leading to an absent hemidesmosome? And how about electron-dense perinuclear bodies? All right, good job. So, you did note that recessive dystrophic EB, Halipo-Siemens type, which is the generalized severe, has a premature stop codon creating truncated type 7 collagen. You did notice that dystrophic dominant EB has a missense mutation causing altered structure of type 7 collagen. You also remember that JEB Hurlitz, also the severe type, has a premature stop codon in the pathway encoding laminin 332, also known as laminin 5. You did remember that EBS severe, also known as the Dowling marrow type, has clumped tonofilaments, and you did remember that transient dermolysis of the newborn has electron-dense perinuclear bodies. Which of the following is characterized by exuberant granulation tissue? If you don't know this, I'm going to come through the computer screen and flick you in the forehead, all right? Which one is it? You can do this. Good job. You knew that. The severe type of JEB specifically. Which of the following systemic findings is characteristic of JEB with pyloric atresia? Remember, the beta and alpha 6 beta 4 doesn't just constrict the pylorus, but it also constricts one other sphincter, the ureters, leading to, that's right, hydronephrosis. Match the defect here. EBS muscular dystrophy, Halipo-Siemens, Dowling-Mera, JEB pyloric atresia, JEB Hurlitz. Yeah, and I know you're probably cussing at me because I have the eponyms up here, but I just want to make sure that you guys are kind of familiar with the eponyms because I don't know how much of the eponyms have been favored out when you're going to do your board exams, or if they're going to keep sneaking up on you. So it's just good to be healthily aware of the subtypes. Anyhow, it's enough talking for that. The EBS muscular dystrophy mutation is in, that's right, plectin. Halipo-Siemens is in type 7 collagen. Dowling-Mera also, what is it? Yep, good job. It's in keratin 5, keratin 14. That's your EB simplex. JEB pyloric atresia is an alpha 6 beta 4 integrin. JEB Hurlitz, laminin 332. Remember, Halipo-Siemens is a type of dominant, no, recessive, yes, recessive dystrophic EB. JEB Hurlitz is the severe subtype, generally severe junctional EB. All the following are characteristics of the recessive dystrophic EB Halipo-Siemens except, what do you think? Good job. And, we didn't go in these in detail. We did go over aggressive SCC. We did go over mitten deformity. Esophageal stricture can be applied as the significant predominant, or not predominant, but the significant oral involvement can lead to scarring down the esophagus. Osteoporosis is something we did not go over, but the key here in terms of test taking is that you should have known that the dominant dystrophic EB Pacini variant it has the albopapuloid lesions. What is the most mild and most common form of EB? EBS simplex localized, also known as Weber-Cockayne. When you see this, what do you think of? Yep, recessive dystrophic EB, Halipo-Siemens. Now remember, if I show you teeth in any capacity, now here you have pitting and some enamel hypoplasia as well, but mostly pitting, enamel pitting. What are you thinking of? Junctional. Good job. How about this exuberant granulation tissue on the neck, huh? Yep. Junctional, generalized severe. How about, what's going on here? We got a little tiny little blister on a toe. Not too bad, right? The rest of the plantar aspect's not involved. Looks like the legs in the background, although out of focus, aren't involved. What do you think we have here? EBS localized. EBS generalized, Kabner, heals without scarring. What do you think? Is that true? Is that false? It's true, typically. Now, Bologna can argue, and scarring, non-scarring should not be the reason you're making a diagnosis ever in the world, because there's a lot of controversy with that, especially as these cases are like low in number and lots of argument. And we talked about this, didn't we, guys? We went through this, huh? So let's go through it again. Primarily involving the palms and soles unspecified. Get a good idea what that is in your head. Primarily involving the axilla and groin. Remember, this is a subtype, or some subtypes we didn't quite go over, but briefly mentioned. How about the herpetiform lesions and arcuate? How about the hyperpigmentation variant? Granulation tissue? How about a confluent PPK? How about prurigo-like nodules? Yeah, you guys got this. Just remember, which ones, what EB simplex generalized looks like. I feel like that one's kind of maybe hard to pin down to herpetiform blisters sometimes. You guys already have been beaten to death with the granulation tissue comment, as well as just knowing that there's an inversa subtype of junctional and dystrophic, as well as a dystrophic pruriginosa type. Now here is the kicker. Just came out, I think within the last few months of me recording this, a new gene therapy, which is just novel and it's topical, and it's called Vyjuvek. It is for dystrophic EBs. How it works is this topical formulation of HSV inactivated for its virulence, HSV1, where the HSV, the virus, actually retains collagen 7A1 gene, and then you're using the virus as a mode of delivery of this defunctive to replace the defunctive collagen 7A1 gene with a functioning one, which is fantastic. Now, this is only indicated in dystrophic EB. Why is it only indicated in dystrophic EB? You know this because that's the only one with collagen 7 mutations. Here are some references. Big shout out to Max. What a great PowerPoint. Hopefully you got something out of this. This is a high yield lecture series. If I missed anything, any comments, any ways you need to remember this or you'd like to remember this, put them down in the comments down below, so we can all learn from them. And hopefully I'll see you in the next genoderm lecture.